Good morning, everybody. I'm so excited to have you all on the line. We're just going to wait about a minute or two just to let everybody else hop on who's going to attend. And I'm really excited about all the content that's going to be shared today. All right, great. It looks like some people are still hopping on, but they are more than free to join whenever they please. We will get this rolling because we have a lot of great information to get through. So my name is Sydney Powell. I'm the one that's been sending you all the emails. I'm in the marketing department here at Revell. I will be the organizer of today's webinar. We're super excited to have you on the line today. Like I said, we have some really great information lined up on all things valuation and management 2021. But before we get started, just a couple reminders. We will be recording the webinar today. So the recording and the slides will be made available to you after the webinar. I'm going to be sending out that thank you email that has that included. And I'll also throw the recording up on the website so that you have it there as well. And we're also going to set some time aside at the end for some questions in case you guys are interested in learning more about anything from the presentation today. So moving on, I'd like to introduce you to our presenters. First, we have Marie Moss. Marie is a coding educator and has been here at Revell with us for 5 years. With over 30 years in healthcare coding industry, she brings a ton of great experience to our team. And then later on, we have Tiffany Richardson, one of our eClinicalWorks trainers. Tiffany brings previous experience as a registered nurse to our training team here at Revell, and her unique clinical perspective has helped tons of ECW users improve adoption and find lasting satisfaction with ECW. So I'm really excited to have both of these professional speakers on with us today. Up next is the agenda. So here's just a brief example of what they will be covering today. Marie's going to cover changes of E&M office visit leveling guidelines, time, office visit and other outpatient service code descriptions, medical decision making, social determinants of health and prolonged services. And then later on, Tiffany's going to cover settings, ECW time-based templates, ECW version 2 coder, and ECW version 2 coder triggers. So everything looks great. One more thing before I pass it on to Marie. I'm sure there's a couple people on the webinar today that might be wondering who we are and what we do and why we're presenting on this topic. So I'm going to give you a little explanation of Revell. We're one of the only end-to-end revenue cycle solutions built for eClinicalWorks users who want an integrated, data-driven, and dependable service. Unlike other RCM solutions that leave your in-house staff following up on claims and answering patient phone calls, Revell offers the expertise, scalability, and efficiency healthcare leaders need to build a richer revenue cycle in a rapidly shifting healthcare environment. We always take a team approach to our success. Revenue cycle management automation is meant to support our solutions, not replace it. Our clients are assigned a client success team led by US performance managers, and these team members come with years and years of experience dealing with RCM challenges, and they're here to serve the day-to-day needs of our customers. You can also expect to work with billing consultant, coding consultant, team leads, and ECW certified trainer, among other team members supporting the whole RCM process, which also includes certified coders and patient service representatives. As a revenue cycle management service, our goal is to really be a partner with our clients. We know reimbursement is a top challenge, and we know that healthcare has changed dramatically, and we care about your success, and we want to give you our knowledge and experience to upcoming changes like our topic for this webinar on the new E&M guideline changes coming in 2021. If you have any questions about how we can help our clients keep up with this industry changes or increase cash flow or anything like that, we'd love the opportunity to connect with you. And after the webinar wraps up, I will let you know how you can get a hold of us. So without further ado, what you've all been waiting for, I'm passing it over to Marie. So Marie, go ahead and take over.
Thank you, Sydney. All right, so let's get started. So what is changing? Well, as we all know, effective January 1st of 2021, the American Medical Association CPT codes for office and outpatient services evaluation and management visit codes 99201 through 99205 and 99211 through 99215 will have a whole different meaning. CMS has adopted these changes as of December 1st, just a couple of days ago, and will soon be sharing the new physician fees. The office visits for established patient services will continue to have their 5 levels, but for the new patient will only be revised to 4 levels. The history and examination components of the evaluation and management will no longer be used to level the code, but will still be required as part of the documentation. And another change will be to level the office visit codes by time or medical decision making. A possible plan would be documentation assistance. We're reviewing the provider's current documentation and leveling it by the 2021 E&M guidelines. Conducting a chart audit and recommendations to identify any risk associated with level of care assignments. A compliance review, holding a client and coding resource consultant meetings to review the documentation audit, provide recommendations, and to discuss next steps. And last, eClinicalWorks assistance, where you'll receive a demonstration of the free E&M Coder new version and provide assistance with progress notes templates. A recommended timeline for the E&M changes would be to begin today by becoming familiar with the 2021 E&M guidelines, confirm software configuration, and practice leveling by time and medical decision making. Here are a couple of resources that you can find on our website. Go to revelmd.com. From the toolbar, click on Resources, then E&M Coding. Here you'll find the American Medical Association quick links, where you'll find the revised medical decision-making chart. Also on this page, you'll find a time audit cheat sheet. It is a creation of Revels. And last, the YouTube video of the guidelines. It's a recorded presentation of the 2021 E&M leveling guidelines to view at your own convenience. So let's review some of the 2021 guidelines for leveling by time. Counseling and/or coordination of care no longer has to dominate the service for leveling an E&M code by time. However, will still be used for other E&M codes. Total time on the date of the encounter includes both face-to-face and non-face-to-face time personally spent by the physician and/or other qualified healthcare professionals. We will learn more about this on the next slide. The physician and other qualified healthcare professionals' time spent in the supervision of clinical staff who perform the face-to-face services of the encounter use code 99211. For shared or split visits, select the appropriate level of service for which time-based reporting spent by the physician and/or other qualified healthcare professionals assessing and managing the patient on the date of the encounter is summed to define total time. When 2 or more physicians and/or other qualified healthcare professionals meet to discuss the patient, only the time of one provider should be counted. And last, when prolonged time occurs, the appropriate add-on code may be reported. The appropriate time should be documented in the medical record when it is used as the basis of code selection. Total time spent on the day of the encounter can include 1 or all 9 of the elements listed. Preparing to see the patient, such as reviewing of tests, obtaining and/or reviewing separately obtained history, performing a medically appropriate examination and/or evaluation, counseling and educating the patient, family, and/or caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals when it is not reported separately by another code, documenting clinical information in the electronic or other healthcare record, Independently interpreting results, once again, that cannot be reported separately on another code, and communicating those results to the patient, family, and/or caregiver. And last, care coordination. And once again, that cannot be reported separately by another code. Some tips for calculating total time. Counting clinical staff time is not allowed for such as taking patient vitals. However, the time for the provider to review those vitals can be counted in the provider's total time. If the provider orders and interprets a test or an x-ray, this cannot be counted for total time due to the time is included in the test or x-ray's procedural charge. Medical decision making. Let's look into these new guidelines. Here are the new long descriptors for each of the office visit codes beginning with the new patient. Notice CPT code 99201 is not listed. It has been eliminated due to it shared the same level of medical decision making straightforward with the CPT code 99202. For the second through the fifth levels, a medical appropriate history and/or examination will still be required, and each code is assigned a total time spent on the date of the encounter. The established patient evaluation and management codes still have 5 levels and each has a new descriptor. Notice that 99211 is not time-based. For each of the other levels, a medical appropriate history and examination will also still be required, and each code is assigned a total time spent on the date of the encounter. With total time and medical decision-making being the only 2 ways to level an E&M office visit services, the short description of the codes will easily identify both types of leveling. The American Medical Association has created a chart for leveling the evaluation and management office visit services. The level of new and established patient codes are now of the same level, such as 99202 and 99212. They have condensed the 3 elements into one chart. Name and complexity of problems addressed, amount and/or complexity of data to be reviewed and analyzed, and risk of complications and/or morbidity or mortality of patient management. To qualify for a particular level of medical decision-making, 2 of the 3 elements for that level of decision-making must be met or exceeded. The concept is unchanged from current guidelines. In the number of complexity of problems addressed, there are familiar statuses of illnesses and conditions: acute, chronic, with exacerbation, severe exacerbation, stable, systemic symptoms, and uncomplicated or complicated illnesses. The risk by not referencing the complexity of illnesses and conditions could affect the chosen level. Something to think about. New to the amount and/or complexity of data to be reviewed and analyzed column, there are categories. And within the category, there are elements. Some levels require 1 or 2 of the categories, and some levels require 2 or 3 elements of the category. Please note in the prescription please note for the prescription drug management, it has been moved to the moderate or 4th level of risk of complications and/or morbidity or mortality of patient management. To assist in appropriate leveling and understanding of the new terminology found in the American Medical Association Medical Decision Making Chart, We have provided their description for status of illnesses and conditions. New to the amount and/or complexity of data to be reviewed and analyzed are external records, external physician or other qualified healthcare professionals, independent historians, and interpretation, and appropriate source. A new addition to the risk of complications and/or morbidity or mortality of patient management, fourth level, is the social determinants of health, SDOH. Social determinants of health are conditions in the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risk. To qualify each social determinants of health, a question should have an anticipatory guidance. For providers who practice pediatrics, Bright Futures has created a list of questions for patients 12 months and younger. Please use the hyperlink. State Medicaid programs transform their delivery systems to improve health and control costs. They have increasingly focused on the role that social determinants play in the health of their enrollees. Each state has a set of rules. Please use the hyperlink to see what your state rules are. Here is a list of the ICD-10 CM codes for persons with potential health hazards related to social, economic, and psychosocial circumstances for the social determinants of health. To accommodate the E&M office visit changes, they added a new prolonged service and made revisions to old ones. Let's look at those. The CPT prolonged service codes 99354 and 99355 will not be used in conjunction with the codes 99202 through 99215 as of January 1st. They will still be used for other office or other outpatient setting codes, though. CPT codes 99415 and 99416 have been revised with identifying the professional type, clinical staff service. It can be of non-continuous services provided on a given day and may be reported for no more than 2 simultaneous patients. CPT code 99417 is a new add-on code for prolonged services of total time. It is to be reported for each additional 15 minutes when the highest level of service being of 99205 and 99215 total time has been exceeded. On December 1st, just a couple of days ago, in the final policy, payment, and quality provisions changes to the Medicare physician fee schedule for calendar year of 2021, there is a new rule. And it is stated as, we are finalizing separate payment for new HCPCS code G2212, once again, G2212, describing prolonged office and outpatient evaluation and management visits will be used in place of the CPT code 99417, which was formerly referred to as CPT code 99XXX. This is to clarify the times for which prolonged office and outpatient evaluation and management visits can be reported. And with that, I am handing it over to Tiffany. Tiffany?
Thanks, Marie. And what we're going to review is the software configuration and templates. So this is based off of ECW setup. So the first thing that you need to consider when setting up your ECW settings for the 2021 changes, the EM changes for 2021, you're going to need to enable your EMV2 coder. It's a license key right now that you can enable if you haven't already upgraded 11 point. You can request for that license key to be updated. Otherwise, when 11.5 comes out, ECW had mentioned that it will be available on-demand content, like other features are available within ECW. Once the V2 coder is enabled, there are some things that you need to keep in mind. The settings. So there is two settings that are involved. One is allow changes in the progress note to the ENM coder sections. So this, you definitely want your providers to have access to the V2 coder. And then the other is allow modify ENM coder configuration. You really want to set that one only to those that are configuring that coder for you. And we'll review all of what the V2 coder looks like. It's currently available in everyone's system as long as it's activated. You may notice in your system, if you have not activated the V2 coder, that you might have just the EM coder, which is very basic, low functioning. There's not a lot of algorithms built in. So you can utilize it, it's just very limited. The V2 coder allows a lot more functionality to really get into that medical decision-making piece of it. So that's one of the settings. Another settings is your practice defaults. Now, I want to come back and mention something about the 11E versus the EXE. 11E being your browser, the newer platform, versus EXE being the older platform. When you enable the V2 coder, you will not be able to access the old basic EM coder within the older platform any longer. You will only be able to access the V2 coder in the older platform. In the browser environment in 11E, you can access either. And so when you go to your security settings and you look for these settings in your practice defaults or in your My Settings, you're not going to see them in EXE because you don't get a choice whether you get to look at EM coder versus EM coder V2. So just keep that in mind when you're looking at these settings. These settings for your practice defaults and your My Settings are going to be very specific to the 11E, the newer environment. So we're looking at the practice defaults. We have the default ENM coder options. So you can override and use the ENM coder V2, MDM based, lowest level exam history or MDM. And then you can also set guidelines by 95 or 97. Now this is a practice default, so this influences everybody that uses the system. But the providers also have a My Settings. So within settings, My Settings, you have your tab user settings. And in your user settings, you will notice if you're in the 11E, the newer version, you will have this EM coder version type. This allows the provider or any other user that is utilizing the coder to be able to signify when they look at the billing window, if they want to only see the EM coder, only see the EM coder V2, or see both but set one as a default. And I'll kind of show you what that looks like in the demo. So two ways of looking at this, like Marie had mentioned, we have time-based versus MDM-based. So time-based is very straightforward as far as what is included. It has to still be documented in the note to represent that this information has been obtained or the time has been spent on it. Obviously, that still has to be documented within the note, but you can do a time-based. This is kind of the preview of what ECW showed at National Conference, what the time-based EM coder would look like when the changes are placed for 2021. If you can see here, the place of service, this already exists in your V2 coder. Patient type already exists. And the guideline years exist, but for 95, 97. So this will look very well the same what you already have in your system for the V2 coder. It's just going to have 2021. And also just keep in mind, with these office or other outpatient services, the 2021 changes only impact these settings. When you drop this pick list down, it'll show additional options like counseling and nursing home visits, that kind of thing, where you can also do those 97, 95 guidelines can be still utilized for those other types of services provided. And you can see you have the chart-based versus ENM coder, which has not been released for the 2021 from ECW yet. They did kind of demonstrate it. It's already kind of built in the system. They're just going to make modifications based on the points that are allocated for each one of the medical decision-making pieces of it. So this is what the EM coder version 2 looks like currently. It's based on 95 and 97 guidelines. You can go in here and select if you want to use a 95 guidelines or 97 guidelines, but keep in mind this has to be set up in the configuration in order for this to drop. So some of the things like Marianne mentioned that are going to be changes is HPI section. The histories are going to be removed from the coding piece of it. It needs to be completed, but it will not be included in your selection of your E&M codes. And the same with the exam. That is also going to be removed. And I mention this because there is a configuration for the exam. And if you want to forego that, there's no need to configure the exam if you're just going to move forward to the risk mapping and complexity. And we'll show that shortly. The thing that they are going to focus on, of course, is that medical decision making. It's that little piece right here in the bottom left corner of your V2 coder. So you have your number of diagnosis or management options. You have your amount or complexity of data to be reviewed and risk of complications and or morbidity or mortality. And then this is just, this is all based off of what was documented in the note. It automatically makes those selections, indicating that this is what level that it is identified based on the documentation that you provided in your note. You also have an add info button. And the add info is going to allow you to put in, that you requested order or old records from a doctor. And when you do select this check mark, it does make the doctor mandatory so that you do have a log of who you communicated with in order to document that you received that point for that. Same thing with old records reviewed or discussion with another physician. I'll show that coder printed report when I do the demo. I'll be able to show that report there. All right, so moving on. V2 coder triggers. So these are the things that are going to trigger your system to say that something needs to identify, or there's an algorithm to be able to calculate those points for you. So the place of service, of course, by selecting that drop down, you also have your patient type, if it's established versus new patient. Your guideline years, of course, there'll be another option for 2021. HPI is removed and exam is removed. You have your medical decision making, the add info button, and then review and calculate. And then when you review and calculate, that's going to put out a report. All right, so let's go and dive deeper to these triggers. So one of the major triggers is in your ICD codes. If you go to menu billing ICD codes, you can go into the ICD configuration window, and when you look at your ICD configuration window, you'll have these two checkboxes here, chronic and acute. Chronic for those chronic type of conditions, and acute for those acute conditions. And that's important because that algorithm is going to basically trigger that. It gets a certain number of points based on the diagnosis, if that diagnosis is a chronic condition or an acute condition. And that is very important to trigger that part of it in the algorithm. Now, the other trigger is the problem list. So within the problem list, which you can access from the treatment screen, but you can also access them from the right chart panel. In your right chart panel under the overview tab, if you go down to the problem list over to the far right, you will have this 3-dot ellipsis. When you select the 3-dot ellipsis, it'll open up a window that looks similar to this. And in this window, you'll see the type, the code, the SNOMED, the name of it, to specify all these different columns specific to this diagnosis. The things that are important here are these 3 items here: specify, risk, and clinical status. Those items will trigger the V2 coder. The only word that works in specify is the word worsening. That triggers the system to say this is a more complicated diagnosis. The risk, of course, if it's high, medium, low. The clinical status, whether it's well controlled, resolved, poorly controlled. Resolved, when you do mark it resolved, it will put out a date over here on the side to indicate that that's resolved. In order to change these items, just click in any of these columns and it's going to open up the problem list notes window. Specify, as I said, worsening is the only word that will trigger anything in the system that it identifies that there's something a higher level here. Nothing in the notes section triggers anything. Risk, low, moderate, or high risk. And then your EM coder. So if it's a new diagnosis, it's going to add 3 points. If it's a new diagnosis with labs, DIs, and RX ordered, it's 4 points. All right, so some other V2 coders is ordering, reviewing, labs, and diagnostic testing. So by ordering, these O's indicate that there's a order, but it needs to be resulted and reviewed. And then it becomes an arrow when it's been resulted or reviewed. The first arrow is for just that specific lab for that specific date or test. The second one is a cumulative report of all the tests that have been done for, say, a CMP, for example. You would have multiple dates for that CMP with all those results appear in your past results section. And the other key part here is the provider's note and timestamp, which is also a practice default. If you want your notes for your past results to appear, which is really nice. So like say for the CMP, and I'll demonstrate this as well, maybe the patient needs to reduce sodium or manage diet or something. You can put your notes in that past results or in that result of that order, and it will actually push into your document, and it'll be on every time you do that cumulative report, a list of the notes that you put for one of those tests. So your past results, it'll look something like this. You'll have your different dates, what their values were, and please ignore the values. I just threw some numbers in here just to get this for demonstration. I understand that these are not reflective of accurate values. And here in this bottom part, this note section, this is what I was mentioning as far as your notes for the patient, what you advise for them to do for their treatment. This is part of that medical decision making, and this will increase the level of complexity of the patient based on all of this being done. So when you're in your lab results window, you can go down here into the notes section, and then you also select reviewed. So in the notes section, you're going to document what you want. That's what puts it into the notes here in these labs, and then select reviewed. And when you mark it reviewed, that's what triggers that it's no longer an O on the right chart panel. It's going to make it a arrow, indicating that it can now be merged into the note because the provider has reviewed that those orders, those labs. All right, so let's look at this risk mapping a little bit closer. As I mentioned before, with the 2021 changes, exam mapping is necessary. So if you're just kind of playing around for the first time with the B2 coder, don't waste your time on the exam mapping for now. If you are doing other services outside of inpatient services that the 2021 changes will influence, you can still do the exam mapping to help assist with that calculation for those other types of services. So there is some use for it, but if you're just trying to get your 2021 changes set up, I would focus on your risk mapping and complexity of presenting problems mapping. So the risk mapping, you have some ICD codes here already. You have your E10, E11, and you also have fracture dislocation. The asterisks indicate that it hits every code that's in there. So that S42.01, 02, 03, whatever those may be, it's going to include all of those in that subset, basically. Over here, specialty mapping, you can also do like your referrals. If you're sending out referrals, it's going to then trigger the system that there's a higher level of complexity to this because we're having to refer the patient out. You can also do your CPT mapping. So if it's a minor surgery, you can go in here to this list and you can add those CPT codes for minor surgeries, for hydration and IV fluids and piggyback, because that's a higher level than that level here. So it's going to create a more complex coding for this patient if they have some of these codes in here. Same thing with fracture or dislocation, and then of course your face-to-face codes. So you want to be sure that you go in here and set this up so that it will trigger your system for it. And then the third tab is the complexity and presenting problems mapping. So in the complexity, you have your radiology, your medicine, and your visualization of images. Medicine isn't really like your medicine like you would think with medications. There is a trigger for that. When you order a medication, it triggers the system that it is a moderate level of complexity based on that V2 coder algorithm. But the medicine here is strictly for kind of like your procedures or what you're doing in the practice for the patient that doesn't fall in their current medication or in their medication treatment. Radiology is all your labs, diagnostics, and then visualization of images is those tests that you do in-house that you are reviewing and you're doing the test and you're reviewing the information with the patient in the office. So it's going to increase the level of complexity. And then you have your self-limited minor ICD mapping as well. So what does that look like? So this is our training environment. So none of this is a live patient. There's no PHI to be concerned with. But I just want to demonstrate what this looks like. I've already built a note. And of course, I wanted to put in HPI just so that it would trigger because the V2 coder hasn't been updated for the 2021 changes, but just so that you can see the MDM piece of it. So currently, this is how it works in the system for the V2 coder. I went in here, documented all this information, added my labs, my ROS exam, documented my vitals, and come down here. I have some assessments, I have some treatment options, and then of course I mentioned your results and then any information with those results, but you also have your past results as I had mentioned earlier in that previous slide. If I go down here to the procedure codes or visit code or next appointment, it all takes me to the billing window, any one of those hyperlinks. I'm going to go into the billing window. And as I mentioned earlier with the EM Coder V2, you have when you select that it defaults to V2, but maybe you want to still see the EM Coder, you have the option to toggle this way. But if you set your My Settings to only show the V2 Coder, you will not have this drop down for the EM Coder basic version. And this is only available in the 11E newer version environment. Once a V2 Coder is enabled in the system, you will not be able to access the old basic EM Coder in the EXE environment, which really the basic version is beneficial is the HPI and the ROS because it's based on the number of categories that are selected. And since that's being taken out, it's not going to be beneficial for these types of services moving in 2021 because it's going to be based on that medical decision making, which is impacted by how you configure the system for it. So I'm going to select EM Coder V2. And when I select that, all right. So you have this chart-based EM coder, and then you have the time-based. So this is very basic, but I showed you before in the previous slide what it's supposed to kind of look like, where you can it'll have the number of elements that are included in that time-based, and you'll be able to put in amount of time that you spent with the patient. Again, with the chart-based, it's going to remove the HPI, it's going to remove the exam for these office or other outpatient services. But I'd mentioned there's other types of services. So if you had selected one of these other services, the 95, 97 guidelines will still apply to those situations. You can mark it as established for a new patient, and then you can also mark your guideline years. Of course, 2021 will be kind of defaulted, I would assume, when ECW pushes that out to only this service, because that's the only one it applies to moving forward to 2021. You also have this question mark up here. If you're ever questioning what is included in those guidelines, it's just a quick reference of the 95, 97 guidelines available right there to you in real time. Moving over here to the number of diagnosis, you can go in here and manually mark these things, but I advise that you stick to whatever your note is documenting because it's going to reflect a more accurate value unless it's not catching it, which means that something needs to be configured to capture that, trigger the algorithm to hit the MDM piece of it. When I talked about add the info, again, you have your doctor's old records requested, reviewed, and any other discussion you had with another provider, it increases the amount of points associated to that encounter. You go down here to the bottom and you select review and calculate. And it's going to put out a little bit of information about what you've selected and why it's saying, okay, HPI is extended, your ROS is extended, your past history is complete, your number of diagnoses is extensive, but your risk of complications is low. But maybe my risk of complications isn't low, but maybe I'm not selecting something, or maybe it's not set up or configured in the system to be able to trigger it that it has a higher complexity. So that, and of course the complexity of data says extensive, and I'll show you what that means when we get to that piece of it. Examination performed isn't going to be important because of course examination is not going to influence the 2021 changes. And then it puts out a code that based on this, and it's because of this risk of complications is low, is the reason it's giving me a 99214. If this was a higher level, it would give me a 215. But let's look at that a little closer. What does that mean? What does it include in those complexity? All right, so we're looking at a printout of this situation, of this encounter, and what it's basically saying is going on with this patient. So we're going to skip past history because that's not going to matter. We're going to skip past examination because that's not going to matter. We're going to go to this medical decision-making piece of it. So we have presenting problems, how it's extensive here. We go to risk of complications. We have over-the-counter drugs that have been documented. So vitamin D was documented. That's why it's triggering the over-the-counter drugs. We have no moderate or high diagnosis here. So if we have some like a minor surgery or one of these other 2 or more stable chronic illnesses, if that was documented in the note, it would then trigger a higher level in this medical decision making. So that's why it's saying low right here. So let's look at some of those triggers. I'd mentioned the ICD codes. So let's go over to menu, billing, ICD, ICD codes. And within your ICD codes window, if you go to the pencil icon in your 11E environment, you'll have these two options, chronic and acute. I would recommend that you print off your first 100 diagnoses that are most often used, and I would just go in there and mark them chronic and acute. And then as you get more and more, just keep going in there and marking them chronic and acute. The other area is the DRTLA, as I'd mentioned with the past results. So if you go to overview and then the second tab over is the documents, referrals, telephone encounters, labs, and actions. And then you are able to then move that information over into your note. First one just being that result itself, second one being the cumulative report. And if it has an O, indicates that this has not been reviewed. There may be results, but nobody's reviewed it. And then it's exclamation if it's like a high abnormality or something like that, then you'll have an exclamation indicating something needs to be done with those. The other area that we look at for the configuration, you're going to go to your reports, and you're going to go to report console. In your report console, you're going to scroll down to E&M coder. If you have not enabled the V2 coder, you will have another option here for enabling its E&M coder activation. If you have not updated to the 11.50 version updates that are coming out, you will have an option here to actually enable it. But you'll have to get a license key, so you'll have to put in a ticket to ECW to request that license key to be activated. They will send you a license key over, and you will go to the report console, you'll click on that activation, and you will paste that code in there, and then it'll activate itself. Then you'll also see this EM coder configuration. When you click on that, as I'd mentioned, exam mapping is not going to be important for 2021, but you can go in here and map it. 95 is very basic. 97 is you have for general, and then you also have for single organ systems for the specialty clinics like cardiology or something. They wouldn't necessarily need to go into a general exam because they're looking specifically, obviously, at the cardiology aspect of the exam. So we go over here to risk mapping. So as I mentioned, you have your identified risk, fracture of location. You can go in here to the list and you can add items. You can go in here to the specialty mapping, add your referring type, and you can go into these minor surgeries, hydration fluids, click and list, and then you can add those as well based on your environment. So my second recommendation is that you go in and you locate your most commonly used CPT codes, any in-house testing that you do, and I would start going and entering these in. Same thing with your complexity and presenting problem mapping. Go in here and add if you're doing x-rays in your clinic, add those in. If you're doing EKGs in your clinic, add those in. If you're doing labs in your clinic, add those in, because all of that's going to increase the complexity of the visit, because not only are you conducting the test, you're also reviewing that test. So it's going to increase that level. And that is it for the software configuration and templates, Sydney. Thank you.
Yeah, thank you, Tiffany. So thank you again, Marie and Tiffany. That was a lot of really great information to take in. So if you happen to miss anything, don't worry. I'll be sending an email later today with the slides and the recording. And now that we've reached the end of the webinar, our presenters are going to take any questions that you might have at this time. So if you do have a question, you can start typing in that chat option that drop down on your screen, and we will get to those. As we wait for some of those questions to roll in, I want to make sure that you know how to get in touch with us if you'd like to learn more about our eClinicalWorks implementation, optimization, training services, revenue cycle management services, anything like that here at Revell. Following the webinar, you will get a short survey, and you can let us know how we did, or recommend other webinar topics, or request for one of us to get in touch with you. You can also just simply reply to one of my emails, and our team will be quick to get in touch with you to see how we can help. We can also set up a discovery call with your practice and one of our representatives. This will help us talk through pricing and next steps for your clinic. If you're interested but aren't quite sure if it's a good fit, I'd still encourage you to contact us so we can put together some detailed information based on eligibility and your specific goals. So it looks like we have a couple questions rolling in. The first one is, what if a provider cannot complete the documentation on the date of the encounter?
Cindy, I'd like to try to answer that.
Sure.
As we all know, that documentation takes about the bulk of time of an encounter. And as Tiffany has just so greatly showed us all these new tips and tricks with the ECW, you can see how you can now set up your system to ease that length of time that is required to get your documentation in. So that is one of the things that we would highly recommend, because there's not going to be any changes. The rule is the documentation can only be accounted for on the date of the encounter. So some of the ideas or tips that or recommendations that we would like for you to think about or to consider is the significance of what you're documenting. Are you documenting for, specifically for medical necessity? Now with the history and examination not being part of the leveling of the new encounter codes, or not the new encounter codes, but for the evaluation and management for the office visits, doing, what information could maybe you do without. So use your templates, look at your favorites, and more importantly, document only what illnesses and conditions that are truly being addressed during that encounter. Thank you, Sydney.
Yeah, that's great. Thanks so much, Marie. Another question, ICD-10 codes for acute and chronic. What does the system recognize for time parameters in regards to ICD-10 codes when managing acute versus chronic conditions?
I can answer that one, Sydney.
Yeah, sure.
Okay, so the system recognizes for acute conditions 30 days since the last time it was added as a diagnosis to the patient's chart. So an example of this, say the patient came in with the flu the first time and they had a cough, and you add that acute diagnosis for cough to the documentation. 40 days later, they come back with another illness, allergy, something, they develop another cough. Because it's been 30 days since that cough was initially documented and diagnosed, and it had been resolved since their previous encounter, after it was diagnosed and followed up and such, because it's after that 30-day mark, it's considered a new diagnosis at that point. So you get that algorithm for a higher level because it is a new diagnosis. For those acute conditions, it's a 30-day expiration on those. For your chronic conditions, it's a 1 year. So if you have a patient with a chronic condition, maybe it resolves, it improves over the year, hasn't been diagnosed again in a year, then it's considered a new diagnosis again.
Great.
Thanks, Sydney.
Yeah, sure. Another question that's rolling in is what items contribute to a low risk versus moderate risk condition?
And I can answer that one as well. All right, so I mentioned something about that low and moderate risk, and when you look at the printout of that PDF that shows the different risks, and as Marie had mentioned in those different categories of what's included in like category 1, those moderate risks are going to be more of your surgical CPT and ICD risk codes like E10 and E11, your IV fluids with additives, your prescription medications that when it's triggered a start, stop, any of that, anything, the splint CPT codes, those closed fracture ICD codes like S52, S42, S62, those are all going to be moderate risk conditions. Your low risk conditions would be examples like they have that over-the-counter medication like I showed with the vitamin D, start, stop, and continue on those over-the-counter medications. So that's still going to trigger the system that you've met, even though it's over the counter. By you marking start, stop, continue, it's still considered a low risk factor. And so it's going to trigger that. Same thing with your surgical CPT codes and your outgoing referrals that are mapped in the therapy sections. So those are some of the examples of low risk versus moderate risk. If you look at that PDF printout, you can kind of go in there and see the check boxes of what's considered moderate versus high versus low.
Okay, great. Another one I'm seeing here is who is included on the time-based model as a qualified healthcare professional?
Okay, maybe I can answer that, Tiffany. As for who are the healthcare providers, they have extended that for the telehealth services. So that's something we need to, not get confused with. Since we still are typical or technically in the pandemic, that may change. So with that, we typically see the providers being the medical physicians, the nurse practitioners, the physician assistants, some of the therapists, trying to think of some other ones, but with that, please be careful whether, like I said, if this is for televisit services, and that is within the pandemic.
All right, thank you. That seems to be most of our questions wrapping up here. So I'm going to go ahead and wrap up the webinar. Remember, if you have a quick minute, to be sure to complete the short survey after exiting the webinar. But thanks again for taking the time to join us for an hour on all things 2021 E&M changes. And thank you again to our great presenters. It's been a really fun time, and I hope you all have a great day. All right, thanks so much.